Hello everyone and welcome to episode 2 of the OBGYN podcast. First off, I want to thank everyone who listened to the first episode, and a special thank you to the few of you who emailed in. All feedback is read and appreciated. I really want to know what you all have to think, so please keep sending it in. This episode is a follow-up to the first episode, which was Opioids and Pregnancy, so if you haven't listened to that episode, I do recommend that you start there. But this one is going to be about opioids and physicians. How do we contribute to the problem, and how can we help solve it? First, I wanted to define the scope of the problem. Physicians can contribute to the opioid problem in two different ways. The first is diversion, right? Diversion is when I prescribe pills to someone, say Mark, and instead of Mark taking them, Scott ends up taking them. This can happen for a variety of reasons. Maybe Scott steals them from Mark. Maybe Mark keeps them in his medicine cabinet and Scott goes and finds them later. Mark doesn't get rid of them properly. All sorts of reasons. But one of the key numbers here, and this is really a startling statistic, is that 75% of opioid abusers start by taking a friend's or a family member's medication. I mean, that's huge to me. So every time that we give, quote unquote, too many pills to a person for their pain, and those pills end up sitting in their house, that is potential for someone else to get addicted to pills. So we really have to worry about that. The second one is chronic pain. Opioids, we know, work very well for acute pain, but their use in chronic pain really isn't that great. And the primary reason behind that, and this is something we talked about in the last episode, so I won't belabor it, is that as we take opioids, we develop a tolerance. And the first thing we develop a tolerance to is the pain-relieving aspects of the opioids, right? And so if you can imagine, if you're taking something for months and months and months, over time, the ability for that pill to take away your pain is going to diminish. That makes them not a very great pill for long-term chronic pain. The other reason is that the longer you take an opioid, the more likely you are to become addicted to it. And we talked again in the last episode about the difference between tolerance, dependence, and addiction, but the point is, the longer you take it, the higher chance that you are to become addicted to it. In one study, they found that nearly 50% of people who were taking opioids for chronic back pain developed a substance abuse disorder in their lifetime. Again, that's huge. And that's just chronic back pain, but it should apply to everything else. So if you have chronic pain and you're taking chronic opioids, there's a 50% chance that you will become not just addicted, but you will abuse them. So according to the CDC, 97.5 million Americans, which is almost a third, received a prescription for opioids in 2014. For a total of 245 million prescriptions. Now, to break that down, about 160 million prescriptions went to 87.5 million people, and that was for acute pain, so there were less than 3 weeks of pills. Right, so that's about 2 prescriptions per person. The rest of the 85 million went to only 10 million people. That's 8.5 million prescriptions per person in that chronic pain, so that's a ton of pills. So physicians can tackle this problem in 2 ways. The first is, in instances of acute pain, is that we can give just the right amount for just long enough, right? And that sounds like common sense, but it's actually very hard to do. We all know patients who, in our case, have a cesarean delivery and never take an OxyContin, right? And then we have some other women who will get a cesarean delivery and then need 3 weeks of narcotics, right? So it's very hard to know who is who. What we end up doing, and I think this probably applies to most doctors, is we end up using a one-size-fits-all. So in our hospital, every person pretty much gets 30 pills of OxyContin to go home with after the cesarean delivery. And I can guarantee you that a lot of those patients either don't use all of it or sometimes don't even use any of it. But we do that because we don't want anyone to ever be at home and be in pain, right? We want them up, moving around, especially in this case, they have a baby at home, right? They have to be up and mobile. And the DEA really kind of supports this approach, right? They wrote in the consensus statement, quote, "Effective pain management is an integral and important aspect of quality medical care, and pain should be treated aggressively." They continue on, "Preventing drug abuse is an important societal goal, but it should not hinder patients' ability to receive the care they need and deserve." Unquote. So we have to do our best to prevent the pills that we prescribe from being used illicitly. At the same time, though, we never want to err on the side of not giving our patients the appropriate care that they need. The other way that we can intervene in this is on chronic pain. Now, this is a very hot topic right now. I'm not the only one talking about it. In fact, the CDC published a list of recommendations in 2016 about the use of opioids in chronic pain, and I'm going to go through them one by one now and talk about them. Their first one is start with a non-prescription or at least a non-opioid therapy for chronic pain. Now, this sounds like common sense, and actually most of these are going to sound like common sense, but this is so true. Opioids don't work over long periods of time, and so they recommend that you use alternative therapies, such as physical therapy, massage, ibuprofen, naproxen, other NSAIDs, and acupuncture. And really, if you talk to people who are into chronic pain, is they really discuss this multidisciplinary approach to chronic pain. The second one is that treatment goals should be established before starting opioids. Again, this actually applies to most medications. Why are we giving you this medication? How long are you going to be taking it? How long will it take for the effects to work? When are you going to stop taking it? How are you going to stop taking it? Right? A lot about medications, actually, and a lot about healthcare and life is about expectations. Right? And so if someone knows how long they're going to be on it and what it should do for them, they're more likely to discontinue it when they need to. The third one is that before you start an opioid, and then again, periodically after you have someone on opioids for a while, is you should really discuss the risks and the benefits. One of the issues to talk about is tolerance. They should expect that the longer they take the opioids, the more they're going to need. They should know about addiction. They should know about the other physiologic effects like constipation. And it's important to continue to discuss these during the course of treatment. The fourth one is you should always start with an immediate release opioid. And they really recommend this mostly because the extended release pills like OxyContin have a much higher potential for abuse. They're much more valuable to people who abuse these. Now, as a little aside here, a few years ago, in the mid-2000s, there were a lot of robberies in pharmacies because people were stealing the OxyContin to sell or to use. And in fact, a lot of pharmacies in my area stopped selling it because they didn't want to get robbed. So the drug companies, in response to this, came up with these abuse-deterrent formulations, kind of like the buprenorphine that we talked about in the last episode, to prevent people from being able to abuse them. Now, this actually worked quite well, but unfortunately, it didn't actually have any effect on the overall opioid abuse. And there's at least one study, and I'll put it in the show notes, but they found that the people in the study, that yes, they stopped abusing the prescription narcotics, but they just transferred over to heroin. And in some ways, that's actually a lot worse, because those people now are at risk for HIV and hepatitis C, which they weren't when they were taking pills. So I really think, at least in this case, that the only people who benefited from this were probably the drug companies because they're selling these more expensive drugs. The next two kind of go together, 5 and 6. 5 is that you want to start with the lowest effective dose, right? And 6 is that you want to give it for the shortest amount of time possible, right? Again, this seems like common sense, the shortest amount of time, the lowest dose is going to limit your potential for side effects and addiction. And we do the same thing in many other areas, especially like hormone replacement therapy. The 7th one is that on an ongoing basis, you should reevaluate the benefits and the harms to the patient and determine whether you should continue the opioids. The 8th one is that you should evaluate for the opioid-related harms on a regular basis and then consider giving something like naloxone to people who are at risk for overdose. Again, I'm going to say this over and over again, the longer you take opioids, the more tolerant you become to them. But the first thing you develop tolerance to is the pain control aspects. One of the last things you become tolerant to is the respiratory depression. So as you keep increasing the dose to get the same effect, you're really just setting that person up for risk for overdose. And so you need to discuss that with them and make sure that they have a remedy at home. And number 9 is using a registry to make sure that people are not getting multiple prescriptions. People would come to one ER and show up to another ER and show up to another ER and then show up to a doctor's office all to get prescriptions in the same week. In some areas, the ERs band together and they would make a list of people who had gone and gotten prescriptions so they would know not to do this. Across the country, and in fact 49 states now, have a registry where before you prescribe any controlled substance, you can go on and check and see how many prescriptions that person has had in the last weeks or month. And so you know that you're not giving a prescription. New York, where I practice, started this in 2013. In one study, they looked at dentists, and they found that after they started the registry, that there was a 78% reduction in narcotic prescriptions. Now, that's a stunning number. Was that a little bit because dentists knew that they were being looked at? Was it because they were checking and seeing that these people were getting multiple prescriptions? It's hard to say. But in any case, 78% reduction is a huge number. The 10th one is that the CDC recommends that before you initiate chronic opioid treatment, you should get a drug screen to make sure that the patient is not already taking something. And then annually, you should do another drug screen to make sure that they are not using any other substances that you're not prescribing. Now, this one's a little controversial to me and to other people. Drug screening is important. You do want to make sure that your patients aren't taking anything else. At the same time, it really fundamentally changes the doctor-patient relationship. It makes it a little more adversarial, confrontational. I suppose if you approach it in the right way, perhaps it won't be, but there definitely is that potential. There is an upside to it as well. You have a little bit of what's called the Hawthorne effect, where just by monitoring something, you are changing the behavior, right? So just because someone knows they're going to get a drug screen every time they come or every year, they're less likely to do the other drug. The 11th one is that they do not recommend that we prescribe opioids and benzodiazepines together. We haven't really talked about benzodiazepines on the show yet, but the reason they recommend that is because the two of them have a combination effect on respiratory depression, and as you'll remember from the first episode, respiratory depression is one of the major causes of overdose, and so that's why they recommend that. The 12th one is, and I think this is one of the most important ones, is that they should regularly evaluate people for opioid abuse disorder, and then you should offer, and if you can, arrange treatment for these people. We know that addiction is going to be ultimate endpoint for chronic opioid use, and we need to be able to recognize that and treat them. Now, this is more difficult than it may sound. Again, in the last episode, we talked about the methadone clinics and buprenorphine treatment, and I always say that anyone who regularly uses opioids for pain should have a relationship with these places so they know where they can send their patients. Now, these are all solid recommendations for our everyday practice, but I want to finish up with one more study. This was a survey of primary care doctors that was published in the Clinical Journal of Pain. What they did is they surveyed 1,000 doctors, and they got 580 responses. Of those people who responded, 100% agreed that prescription drug abuse was a problem in their community. But, interestingly, only 25% thought that pill diversion was a problem in their practice. Now, this is common when it comes to drug abuse. Everyone thinks that it's a problem, but not that it's happening in their town or their school or their family. So we as doctors need to recognize that of course there's going to be a problem even in our practice. And we really need to think about what and how much medication we give for pain. We need to ask ourselves, is there a better medication for our patient's pain? Can we give less? Can we give lower doses? And do we need to do a better job identifying those who need our help? In some ways, drug addiction is a zero-sum game. Once someone starts abusing drugs, we can push them to other drugs by our policies, but we can only really affect the number of drug addicts by either stopping the addiction before it starts or treating them once they are addicted. I don't want to make it sound that I don't think that drug abuse deterrents don't work or aren't effective. It's just that without treatment and prevention, we're just changing the face of addiction. All right, well, that's episode 2. Thank you for listening. It was a little bit of a short one. I will be back in 2 weeks. We'll be talking about pelvic inflammatory disease. Again, if you have any feedback, please send it to me. It goes to feedback@obgyn.fm. And until the next episode, thank you very much.